Argon plasma coagulation for Barrett's esophagus with low-grade dysplasia, a randomized trial with long-term follow-up on the impact of power setting and proton pump inhibitor dose. Introduction. Barrett's esophagus, BE, is a pre-malignant condition associated with progression to esophageal adenocarcinoma that involves a multi-step process from non-dysplastic Barrett's metaplasia through low-grade dysplasia, LGD, and high-grade dysplasia, HGD, to cancer. Endoscopic ablation of Barrett's mucosa followed by squamous reepithelialization can stop this process and reduce the risk of cancer, and is therefore recommended in individuals with Barrett's dysplasia. The main methods used in endoscopic ablation of BE are radiofrequency ablation, RFA, and argon plasma coagulation, APC. Both have been shown to reduce the risk of neoplastic progression in randomized controlled trials, RCTs. A recent RCT directly comparing RFA and APC showed similar efficacy of these methods in ablation of Barrett's metaplasia and dysplasia, and similar safety. However, the cost of APC was substantially lower. Whereas efficacy and safety of APC for the ablation of BE have been proven, the treatment protocol has not been standardized for factors that may affect results, such as the APC power used for ablation and the dose of proton pump inhibitor, PPI, administered after ablation to promote healing of the mucosa and squamous reepithelialization. In addition, long-term efficacy data are limited to a few studies evaluating exclusively or predominantly patients with non-dysplastic BE. The aim of this randomized study was to evaluate the impact of APC power setting, 90 versus 60 watts, and PPI dose, 120 versus 40 milligrams of omeprazole per day, on the efficacy and safety of APC in individuals with BE and LGD. The long-term outcomes of APC for BE ablation were also prospectively evaluated. Background. This study evaluated the impact of power setting and proton pump inhibitor dose on efficacy and safety of argon plasma coagulation of Barrett's esophagus with low-grade dysplasia. Methods. 71 patients were randomized to APC with power set at 90 watts or 60 watts, followed by 120 milligrams or 40 milligrams of omeprazole. The primary outcome was the rate of complete endoscopic and histologic ablation of BE at 6 weeks. Secondary outcomes included safety and long-term efficacy. Results. Complete ablation rate in the 90-watt 120 milligrams, 90-watt 40 milligrams, and 60-watt 120 milligrams groups was 78%, 18 of 23, 60%, 15 of 25, and 74%, 17 of 23, respectively, at 6 weeks, and 70%, 16 of 23, 52%, 13 of 25, and 65%, 15 of 23, at 2 years post-treatment, differences not significant. Additional APC was required in 28 patients, 23 residual and 5 recurrent BE. At median follow-up of 108 months, 66 of 71 patients, 93%, maintained complete ablation. No high-grade dysplasia or adenocarcinoma developed. Overall adverse events, 97% mild, did not differ significantly between groups. Chest pain and discomfort was more frequent in patients receiving 90 watts versus 60 watts of power, p less than 0.001. One patient had esophageal perforation and 2 developed stenosis. Conclusions. APC power setting and PPI dose did not impact efficacy and safety of BE ablation. Complete ablation of BE with LGD was durable in more than 90% of patients without any evidence of neoplasia progression in the long term.